Good evening, everybody. Today's talk is going to be on post-operative imaging in congenital heart disease. This being the first part of the talk, we're going to focus only on the cyanotic congenital heart disease and its post-op manifestation and its imaging and complications. First, we deal with the palliative surgeries. In dealing with the shunts, first the systemic to pulmonary artery shunts. These are primarily used in pulmonary stenosis or atresia as a first-stage procedure to treat different forms of single ventricle. The most commonly done procedure is the modified Blalock-Taussig shunt. So what is this shunt? In a classic Blalock-Taussig shunt, the subclavian artery is anastomosed. This is a end-to-side anastomosis which is performed between the subclavian artery to the same sided pulmonary artery, but on the side which is opposite to the descending aorta. As with any other shunt, the complications are usually related to shunt obstruction, stenosis with secondary lung perfusion deficiency, stenosis with pseudoaneurysm typically at the site of the anastomosis, and over a period of time there tend to be pulmonary hypertension and left ventricular dysfunction due to volume overload. Now here is a 6-month-old infant who had pulmonary atresia and increasing cyanosis, and after the placement of modified Blalock-Taussig shunt, what we see here, this is the shunt here, the subclavian artery, and this is the pulmonary artery to which it was anastomosis. Is everybody able to end-to-side anastomosis? The classic Blalock-Taussig shunt is a classic end-to-side anastomosis performed between the subclavian artery to the same-sided pulmonary artery on a side which is opposite to the descending thoracic aorta. The complications, just like I listed out, obstruction, stenosis with lung perfusion deficiency, stenosis with pseudoaneurysm at the site of anastomosis, pulmonary hypertension, and over a period of time, left ventricular dysfunction due to volume overload. Now, here's a 6-month-old infant who had pulmonary atresia and increasing cyanosis after placement of the modified Blalock-Taussig shunt. What we see here is the occluded shunt, because of which there is absent contrast opacification and the segment is not opacified. There is a pseudoaneurysm here at the site of anastomosis, and we also see the dilated ascending thoracic aorta developing some long-term volume overload. Now next is the modified Glenn shunt or a hemifontan procedure. This is basically a cavopulmonary arterial shunt performed during infancy and children in the age of 5 to 8 months. There is a single anatomic or functional ventricle such as a tricuspid atresia or any other type of hypoplastic left or right ventricle. This is done in anticipation of a fontan circulation later, in which the systemic return enters the pulmonary arteries directly. So here is the modified bidirectional Glenn shunt, where the superior vena cava is cut off from the right atrium and is connected to the pulmonary artery instead. So this is basically a cavo arterial shunt. Now this is followed by what is called by the Fontan's procedure. Now this can be done in 2 ways. One is through a lateral tunnel procedure, which is basically a intra-arterial tunnel. Here a baffle is placed within the right atrium, which directs the blood from the inferior vena cava to the pulmonary artery directly, bypassing the right atrium. Similarly, we have a Glenn shunt sitting here where the blood from the superior vena cava is also entering the pulmonary artery. So this is basically a procedure in which the right atrium is completely bypassed. The right and left pulmonary arteries are interconnected, and the pulmonary trunk, here we see that the pulmonary trunk is disconnected from the heart. So this entire process, the right atrium is excluded from the systemic venous circuit. Whereas when we do an extra cardiac Fontan procedure, the same baffle, instead of being placed within the right atrium, is placed behind it. This is an extra cardiac conduit, whereas an intraatrial baffle is or a lateral tunnel procedure is done within the right atrium. This is the only difference between these 2 procedures. What is the advantage of this procedure? It does not increase the volume load on the ventricle. whereas its limitation is that an anatomically adequate pulmonary vascular bed with low resistance is mandatory for this operation to work. The goal of diagnostic evaluation, typically when they ask for a pre-Fontan evaluation, is to identify hypoplasia of the pulmonary arteries and to look for stenosis, grade the stenosis, and tell how severe the stenosis is. Again, showing the original Fontan procedure in which the right atrium and the pulmonary artery are connected, and here's a Bjork modification in which a conduit is placed between the right atrium and the right ventricle. Now, what are the complications of Fontan circulation? Because there is atrial enlargement, it gives rise to thrombotic events and arrhythmias. There can be atrioventricular valve regurgitation. There can be stenosis of the cavopulmonary anastomosis, stenosis of the pulmonary arteries. Pulmonary arteriovenous malformations can arise because of the change in anatomy and the functional pressures. Collateral veins or arteries may evolve over a period of time. And long term, there can be ventricular dysfunction, ischemic complications due to surgical coronary artery lesions, and patients can also develop protein losing enteropathy. Here's a patient with, this is a 23-year-old man with modified Glench and done for tricuspid atresia. What we see here is markedly narrowed stenosed right pulmonary artery at the site of anastomosis. The S3C is markedly dilated, and to provide a collateral blood flow, the hemizygous and azygous system of venous channels have opened up. What is also important to see is that the left lung perfusion has markedly reduced, so also at the upper lung segment on the right. Now coming to pulmonary artery banding. Pulmonary artery banding is basically a staged approach to more permanent repair in patients with cyanotic congenital heart disease, where they have an unrestricted pulmonary flow and they are at risk of pulmonary hypertension. So this is basically a palliative surgery in order to take care of the pulmonary hypertension. And it is also used to prepare the left ventricle in patients with D-TGA who are slated to undergo atrial switch procedure later on. So as with banding anywhere else, this is where the pulmonary artery band is placed right in the mid segment of the main pulmonary artery in order to regulate the arterial pressures. So this is basically a surgical ligature around the mid portion of the main pulmonary artery, causing artificial pulmonary stenosis and in order to reduce the systolic pulmonary arterial pressure. Now, repeated progressive occlusion and reopening are possible with now implantable devices which can actually behave like adjustable pulmonary arterial bands. So these bands can be occluded or reopened according to pulmonary arterial pressures that are desirable to be obtained. Now, this is a shaded surface display of the 3D MR angiography image, which is showing the correct placement of the pulmonary band. This is the pulmonary band here. This is the right ventricle here. The aorta and the left ventricle is in the right. So, what are the complications of band? As with banding procedures elsewhere, the band can get eroded. It can migrate distally. There can be pulmonary insufficiency due to dilatation of the annulus. There can be long-term subaortic obstruction due to reduction of ventricular volume and induction of a ventricular hypertrophy over a period of time. Now, this is an 8-year-old boy with neonatal pulmonary artery banding in order to correct large VSD and the right aortic arch. So, what we see here is the erosion of the band, and this because of the erosion, this has given rise to a pseudoaneurysm. This is a false aneurysm here, and here this is the region of the band erosion. Here is a 15-year-old girl presenting with increasing cyanosis whose double outlet right ventricle and unrestricted pulmonary flow were palliated in infancy using a pulmonary arterial banding. So, what we see here is a coronal MIP image showing banding-induced stenosis. This is the area of stenosis at the main pulmonary artery. This is a short axis image at the level of mid ventricle, which showing right ventricular hypertrophy and leftward displacement of the septum. This is hard to imagine, but usually the septum is going to be convex to the left ventricle. Here we see that it is somewhat flattened or maybe displaced to the right. This is basically due to pressure overload induced by the pulmonary artery banding. What is Rastelli procedure? This is primarily done in patients with D-TGA who are presenting with a large VSD and obstruction of the left ventricular outflow tract. The long-term results with this technique are not optimal and typically gives rise to complications such as stenosis of the extracardiac conduit with or without regurgitation, therefore leading on to left ventricular dysfunction. Now, the right ventricular dysfunction is basically due to abnormal pressure, volume, load, which may be because of conduit dysfunction. It may be due to obstruction of the baffle from the left ventricle to the aortic valve or branch pulmonary artery stenosis. So this is typically how the Rastelli procedure is done. A prosthetic tunnel is constructed across the left ventricle. So from the left ventricle to the aorta. Yeah, this is the tunnel being constructed through the ventricular septal defect. So we are achieving the closure of the ventricular septal defect as well as a channel formation from the left ventricle to the aorta. And the continuity between the right ventricle and the main pulmonary artery is restored using an extracardiac conduit. So these are the two procedures that are done in Rastelli. So this is an anterior 3D shaded surface display MR angiogram, which is showing a narrowed and tortuous conduit from the right ventricle to the pulmonary artery. This is the narrowed conduit that is seen here. The patient had undergone a Rastelli operation for D-TGA. The signal loss seen here on this image is basically due to stenotomy sutures, stenotomy wires. Now coming to corrective surgeries, first we take Teleradiology E-teaching, of course the most commonly performed operation. Here it is basically surgical repair via closure of the ventricular septal defect and thereby relieving the RVOT stenosis. The most common complication again here is going to be pulmonary valve regurgitation, thereby leading on to right ventricular dilatation, tricuspid regurgitation, arrhythmias and biventricular dysfunction over a period of time. Now the corrective surgery for TOF basically involves the closure of the VSD using a patch and widening of the RVOT with patching of the infundibular tract. So what is the post-op appearance of these two procedures? Now here is the VSD closure. This bulge seen over here is the patch that is left after the VSD has been closed. This is a 20-year-old patient who underwent surgical repair for TOF, and this is how the appearance of the right ventricular outflow tract patch, which is done for relieving the RVOT stenosis. What are the complications after transannular patch repair or extensive infundibular muscle resection? There can be dyskinetic regions and focal or diffuse aneurysms along the course of the RVOT. There can be delayed enhancement of the right ventricular outflow tract. This is basically due to fibrosis and it is picked up on MR on delayed enhancement sequences. And it is associated with RVOT dilatation and ventricular dysfunction. An enlarged RVOT can cause cranial elongation and rotation of the left pulmonary artery, thereby causing a functional stenosis. Now here is a patient, 20-year-old man with surgically repaired TOF who presented with dyspnea on exertion. We see here pulmonary valve turbulence due to regurgitation. The same here, same turbulence or jet seen across the tricuspid valve, both of which are indicative of stenosis and regurgitation. Now this is a 22-year-old woman presenting with dyspnea, had undergone surgical correction of TOF. What we see here on the short axis images is an aneurysmal dilatation of the RVOT patch. And if we do short axis inversion recovery sequences, then we are able to pick up the fibrosis as seen there as delayed enhancement. This thin line of enhancement here seen on the short axis images, inversion recovery images, shows the line of fibrosis, which shows up as delayed enhancement. Now this is a recon shaded surface display of a get enhanced 3D MRA. Now what it is showing here is cranially elongated and sinking of LPA at the root distally, distal dilatation or aneurysmal dilatation of the LPA distally. Proximally it is kinked and distally dilated, basically due to secondary to aneurysmal dilatation of the RVOT. RVOT we see here is quite dilated. What are the other complications that can be recurrent or residual stenosis of either the RVOT or the pulmonary valve annulus due to myocardial fibrosis or insufficient surgical widening of the outflow tract? The branch pulmonary artery stenosis with decreased lung perfusion or secondary pulmonary aneurysm. This is not primarily a post-op complication, but is detected after the primary anomalies are surgically repaired. It can be residual ventricular septal defect. These are quite rare and need quantification as appropriate. So whenever we are doing the MR reporting, we need to quantify the residual ventricular septal defects, if any, and where possible flowmetry is available, surgical the QP/QS ratios need to be provided. The aortic valve or aortic root replacement is occasionally required to correct the progressive aortic dilatation with aortic regurgitation. So whenever doing these MRs, we also need to comment on the status of the aorta, whether it is dilated, and to provide measurements at each level. Now coming to dextrose transposition of the great arteries, primarily treated with an atrial switch procedure, which goes by the name of mustard or Senning procedures. Typically, both these procedures are complicated by baffle leakage or baffle obstruction, thereby leading on to right ventricular hypertrophy and enlargement, and over a period of time, the right ventricular failure. Now, here's a pictorial representation and MR images to display the same. What happens in these procedures is that a left atrial baffle is placed behind the left atrium, whereby the systemic flow from the vena cava are directed across the baffle into the left atrium to the left ventricle. The left ventricle then pumps the blood to the lungs. The purified blood then enters the right atrium through this venous ostia, gets pumped across the mitral valve to the ventricle, and thereby again to the aorta. So the atrial baffle of Senning procedure is basically used for dextroposition of great arteries, and this procedure involves isolating the mitral valve from the pulmonary venous drainage. So the pulmonary venous blood thereby enters the posterior pulmonary venous atrium and flows exteriorly across the tricuspid valve. So here the baffle placement is shown here. The systemic flow from the SVC and the IVC is entering the baffle. This is the baffle placement and the blood in the baffle going on. So the across the left atrium, it is going into the left ventricle. Here's a 17-year-old girl who presented with dyspnea on exertion. Patient had undergone atrial switch procedure in infancy. Here we see that over a period of time, there is right ventricular dilatation and hypertrophy. Again, we see that the right ventricle is quite dilated, and this is where the left atrial baffle is placed, and thereby isolating the mitral valve. Now, a surgical treatment of choice in neonates with dextrose TGA is a Jatene arterial switch procedure. This is the arterial switch where they remove the great vessels from their native ventricles and switch them. So typically on the MR, the steppish shaded display is going to show an aorta which is surrounded by the pulmonary arteries. So this is the arterial switch procedure which is performed, which involves removing the great vessels from the native ventricles and switching them to the contralateral ventricles. So there is also reimplantation of the coronary arteries into a new aorta, which is shown here. This is a new aorta that they have created, and the coronary arteries are reimplanted. This procedure also goes under the name of Lecomte maneuver, which is performed to bring the branch pulmonary arteries from their original posterior position to anteriorly. So here we see that the pulmonary arteries are implanted anterior to the aorta. Now this is a patient, 6-month-old infant with D-TGA after arterial switch procedure. Now the echo showed bulging in the inferior aspect of the left ventricle. Now the MR confirms the same findings, where there is a pseudoaneurysm at the base of the left ventricle. Yeah, this is the pseudoaneurysm at the base of the left ventricle. So today we revised the palliative and corrective surgeries that are done for congenital heart disease, and the different procedures and its imaging manifestations, the complications and how they are to be detected, and what are the different imaging things that we need to look for in the complications. If there are any questions, I will take them now.